Okay, so if you've watched the video on basal insulin, now we're going to talk about bolus insulin. Hopefully, if you have type 1 diabetes, you are already on a once a day basal and a quick acting bolus, which is the newer insulin molecules like aspart, lispro or glulisine. Okay, I hope you are not taking MPH or premix 70/30 insulin or R regular insulin. And the ideal situation would be that you're on an insulin pump where all of your insulin, whether it's basal or bolus, is a rapid insulin molecule, either aspart, glulisine or lispro. Okay, for those of you who are on injections, we would now talk about how to understand what is an insulin bolus. What is an insulin bolus? So we talked about your basal, which is usually low between midnight and 3 a.m. Usually around dawn, it starts to go a bit higher where you need a bit more insulin. So your basal needs go up there. That's why you sometimes wake up with a high. Okay, and your doctor will tell you whether you should fix your morning sugars by increasing the basal glargine or by taking a small dose of quick acting insulin in the mornings. Okay, now that's your basal, is that straight line, the wavy straight line. Okay, these bumps which you see are examples of how somebody who eats 3 meals a day, how their management would look. So it's a quick acting insulin dose for breakfast, a quick acting dose for lunch, and a quick acting dose for dinner, assuming they are eating carbohydrates, carbohydrates, carbohydrates. What are carbohydrates? Carbohydrates are the food which, when you eat them and digest them, they directly turn into glucose. Within a matter of 2 hours, they will turn into glucose in the system. Those foods require quick acting insulin. Okay, and your doctor is supposed to work with you to calculate your precise carbohydrate ratio. What do I mean by that? Let's say you eat a banana. You could eat the same banana for breakfast or for lunch or for dinner, and your body and that banana might have a different relationship depending on the time of day. The same way your basal needs change through the day. Your body has a hormonal clock. Your body has a circadian rhythm. So and it has different activity levels at different times of the day. And we usually are quite similar from day to day. We have very similar habits. So generally your carbohydrate insulin ratio, or what we call insulin carbohydrate ratio, ICR, is pretty stable for different times of the day. And your doctor and you and your nutritionist need to go through your food logs in great detail. This is where your note taking is extremely important. You need to come with a lot of data to us. I know it's a lot of work. It's never easy to get this thing figured out, but it works. I've seen it work. I've seen people come to us with blood sugars going as low as 15, severe hypoglycemia, life-threatening, and then going up to 400 in the same day. And such people have managed to find a way to be within 80 to 140 all day long with pretty stable doses, because they figured out their basals and they figured out their boluses. So what they did was they brought in a lot of data for us to analyze. What's the data you need to look at? What did you eat? How much did you eat? You need to learn how to count the carbohydrates. Every banana is not the same size. Every roti or chapati is not the same size. Every serving of rice is not the same size. So if you say, I had dal and rice, and my sugar went high some days and it went low some days, well, that's because you've not yet figured out the insulin to carbohydrate ratio. The only time someone with type 1 diabetes has very unstable sugars, even though they think they're eating the same food, is because they've not figured out these patterns. There is a formula. Your body is not crazy. Your body is very predictable. For the most part, we can figure these things out together. Okay, so I'm trying to give you hope. As much as there is work to be done, there is hope that we can figure out the formula. I have spent hours and hours on these things with patients, and we found the formula. Okay, so just have faith, don't give up. You can have a stable, amazing life. Just work on this information, okay? So 10 minutes before the meal, you would take your dose according to your insulin carbohydrate ratio, whether it's breakfast or lunch or dinner, and that would cover that food. Now, sometimes when you're about to eat, your sugar is high, and you are counting the insulin for, let's say, for the banana, but your starting sugar before the banana is already 200. So you need some insulin for the banana, and you need some insulin to bring that 200 sugar down. So your doctor will look for days where you didn't eat anything and you took a dose for the 200 just to bring it down. And they'll say, oh, you know what? 2 units brought the blood sugar down from 200 down to, let's say, 140. 2 units brought it down to 140. That means 2 units brought it down by 60 points. That means 1 unit brought it down by 30 points. That means the insulin sensitivity factor is 1 unit brought down the sugar by 30 milligrams per dl. Now that insulin sensitivity factor also is different at different times of the day. So your doctor will have to look for patterns. When are the times that you took correction insulin? This is what we call correction insulin, and this is the meal insulin for food, bolusing for food, bolusing for a high sugar. Okay? Bolus means quick acting insulin. Bolusing for food is carb ratios, ICRs. Bolusing for correcting a high sugar is insulin sensitivity factor. What we try and do is take all that insulin in one go. We don't want you being pricked all day long, and plus we don't want some insulin is coming and some insulin is going and we don't know what's happening. Then we cannot really figure out, because it's like a fish market. There's like way too much movement happening, way too much of turbulence. It's easier and more smooth to learn your patterns if you take your ISF and your ICR together in one go. So if your sugar is high before the meal, you take your correction dose and the food dose at once. And if you want to see how that worked, did it work or not, you check 2 hours later. So sometimes patients come to us with 3 blood sugar readings a day. They check over here, they check here, and they check here. But there is 24 hours of movement happening. So in the initial phases, you will feel that you're going a bit crazy with the amount of sugar checking you're doing. You're really checking a lot. 6 to 8 checks a day, pre-post, 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 and at 3 a.m. If you can come with those numbers to your doctor and your doctor knows how to manage, you will be able to figure out patterns. There are patterns. You just have to put on your detective hat and figure out the mathematical formula. It's not random. So if you say, my sugar is high every other day, it's never the same. That only means you've not figured out the pattern. It doesn't mean you have a crazy body. It just means there is information that is waiting to be discovered. So that's about the bolus insulin. Let's say you think your insulin's not working, no matter how much you take, it just doesn't come down, it just doesn't come down. You need to check if your insulin has gone bad. You need to check if it's being injected into a site where there is a bit of scar tissue or fatty nodules under the skin from repeated injections going in the same space. That's why you need to rotate like a W or an M, okay, so that you don't come back to the same spot. You have to come back to the same spot after you've had a turn in all the other spots on the abdomen. You have to pinch the skin, okay? You cannot go straight into muscle. Do not inject into muscle, whether it's your basal or your bolus. You have to pinch the skin and make sure you stay in this right under the skin for about 10 seconds, release the pen, and then come out, okay? There should not be blood on the tip of your needle. If there is blood, that means you probably hit a muscle and you're going to have unpredictable sugars because you didn't get the dose properly. You should not see air bubbles. The insulin needs to be stored at the right temperature. If you're from India, it's hot all the time. It's too hot for insulin. So you might need to keep it in the fridge and then check based on your local weather whether you're going to be keeping it at room temperature or not. Don't keep it in your car on the dashboard. It will get cooked. It's a sensitive protein. The insulin will go bad. Okay? And the final thing, which I've done a separate video on Instagram about, is if you feel that when your sugar is high and you take 10 units, 12 units, nothing's happening, it's staying high, 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 you're on more than 20 to 25 units of insulin per day, total, basal plus bolus together, then you're probably looking at some insulin resistance, which means you have actually entered into the world of type 2 diabetes, even though you started with type 1. you can still get the problems of type 2 diabetes. I have a whole separate video on that on Instagram, and you can understand what are the causes of that, and that's where lifestyle change comes into the picture. That's a whole new topic for you. Understanding nutrition, understanding sleep management, stress management, exercise patterns, intermittent fasting. Patients with type 1 can do intermittent fasting, but obviously you need your doctor to supervise that. So don't try any of this alone. All of this requires a highly qualified medical team so that you can do this safely and not suffer so much. You deserve to have stable blood sugars for the most part, and it is possible. So good luck.